Can I start, sir?
Yeah. Ravi,
Yes.
can you start?
Yeah, yeah, please.
Okay.
Good evening, all. Today we'll be discussing about diaphragmatic hernia. Coming to the anatomy of the diaphragm is a musculo-membranous structure separating the thorax from the abdomen. It is a dome-shaped structure that functions as a main muscle of respiration and is essential for the breathing process. It is a convex. It has a convex upper surface and that forms the floor of thoracic cavity and a concave undersurface to form the roof of abdominal cavity. And the diaphragm is develops from the four major embryological components, which is transverse septum, which forms the central tendon, pleuroperitoneal membranes, which close the pleuroperitoneal canals, and mesentery of esophagus, forming the crura, and body wall mesoderm, contributing the peripheral parts. The diaphragm mainly comprises a central tendinous part from which muscle fibers radiate in all directions towards their peripheral attachments. The sternal parts originates as a paired slip of muscle from the xiphoid process and the aponeurosis of the transverse abdominis muscle. In coastal part, the muscle fibers arise from the cartilages of seventh to eighth ribs and the cartilage and bony portions of the ninth rib and the distal bony portion of two of the 10 to 12 ribs. Posteriorly, the in lumbar portion, the diaphragmatic muscles arise from the crura and medial and lateral arcuate ligaments.
Okay. Hmm.
Yes. The crura arise from the anterior surface. The crura arise from the anterior surface of the L1 and L1 to L4 vertebra on the right and L1 to L2 on the left, as well as from the intervertebral disc and from the anterior longitudinal ligaments. The crura are tendinous at their origin on the vertebra, becoming increasingly muscular as they ascend into the diaphragm. These crural fibers pass superiorly and anteriorly, forming the muscular arms that surround the openings of the aorta and the esophagus, and they insert on the central tendon. The pattern of the crural arms at the esophageal hiatus is variable. The most common type is type 1. It is up to 45 percentage. In this, the esophageal hiatus is formed by the muscular contributions arising only from the right crus. In type 2, the esophageal hiatus was formed by the muscular contributions from right and left crura. In type 3, the right and left muscular contributions arise from right crus with an additional band from the left crus. In type 4, the right and left muscular contributions arise from the right crus with two additional bands arising from the left crus. In type 5, the contributions arise only from the left crus. In
Does
type
this,
6,
okay, complete this.
yeah. In type 6, the right and left contributions originate from the left crus with additional bands, one from the right crus and one from the left crus.
Does this origin has any significance either to the etiology or what you do surgically when you are dealing with hernia?
Yes. Will be.
I mean to say, is there any particular higher incidence in one of these types?
Mm,
I don't think so.
yes.
So
No.
it's
And I
not
don't think
relevant.
type of crural arising, we cannot make out clinically when you are operating for diaphragmatic hernia or a hiatus hernia.
Correct,
It's
correct.
only embryological importance.
Mm,
Okay.
yes.
Okay, continue.
And coming to arcuate ligaments, the medial arcuate ligament is a tendinous arch covering the psoas major muscle, and medially it attaches to the side of body of L1 vertebra, and laterally it connects to the front of transverse process of L1 vertebra. The lateral arcuate ligament is also a tendinous arch covering the upper part of the quadratus lumborum, and medially it is attached to the front of transverse process of L1 vertebra and laterally to the lower border of 12th rib. And the medial margin of two crura forms a tendinous arch across the front of vertebra. It is called median arcuate ligament. The diaphragm has three major openings. The first is the caval hiatus lies at the level of T8 vertebra in the central tendon. It allows the passage of inferior vena cava and branches of right phrenic nerve. The next is the esophageal hiatus. It is at the level of T10 vertebra. uh, it is T10 vertebra which arise from the muscle fibers derived from right crus or the left, and it allows the passage of esophagus, the left, right and left vagal trunks, on the esophageal branches of left gastric vessels and the lymph vessels. And the aortic hiatus lies in the anterior to the body of T11, T12 vertebra between the crura, and it allows the passage of aorta and thoracic duct and azygous vein. And the foramen of Morgagni is found in the areolar tissue between the sternal and costal part of the diaphragm, contains the superior epigastric vessels and the lymphatics of the abdominal wall. And the sympathetic trunk runs posteriorly below the medial arcuate ligaments.
That's good. Mm.
Yes. The major blood supply to the diaphragm is to the inferior surface. It comes from the inferior phrenic arteries, which arise from the aorta or the celiac axis just below the median arcuate ligament of the diaphragm. And the arterial supply to the superior surface of the diaphragm consists of two branches from internal thoracic arteries, that is the pericardiophrenik and musculophrenic arteries, and the two branches from thoracic aorta and the superior phrenic arteries. And the venous drainage on the superior and the inferior surface, the veins runs along with the arteries, and posteriorly there is some local drainage into the azygous and hemizygous veins.
Good detailed presentation of anatomy. Continue. Yeah.
Yes. And lymphatic drainage, almost all diaphragmatic lymph nodes lie on the superior surface of the diaphragm. These nodes can be divided into anterior, middle, and posterior groups. They receive drainage from the upper surface of the liver and the gastroesophageal junction and the abdominal surface of the diaphragm. These efferent lymph vessels from these nodes drain upward to parasternal and mediastinal lymph nodes anteriorly and to posterior mediastinal and brachiocephalic nodes posteriorly. Coming to the nerve supply, the right phrenic nerve enters the diaphragm to the central tendon just lateral to the opening of inferior vena cava, and the left phrenic nerve pierces the superior surface of the muscular portion of diaphragm just lateral to the left border of the heart. And the peripheral portions of the pleura and peritoneum have independent sensory nerve innervation that arises from 7 to 12 intercostal nerves.
In the anatomy, just go back. In the
Yes,
anatomy that you mentioned so far,
yes.
which part of the anatomy is important as a surgeon?
Mm.
Anyone? You mentioned arterial supply, venous drainage, lymphatic drainage, nerve supply. Which one is you are more interested as a surgeon?
Nerve supply, sir,
Ah,
Yeah, where does the referred
yes.
pain is pointed by the patient?
to the shoulder.
Shoulder, shoulder.
Why?
Mm.
Why?
It's the same
Diaphragm.
innervation, sir.
No, what is the origin of phrenic nerve?
C3 to C5, sir.
Are you sure? Yeah. And if you should know about the phrenic nerve origin, its entire course from the neck uh, through the chest into the diaphragm. Then you will know the nerve roots for the nerve sensation to the shoulder tip also. That's why it's a referred pain. So it's the nerve supply that is more important as a surgeon to recognize. Okay, you should
Yes,
read and learn about phrenic nerve, both right and left
yes,
origin, its course and its insertion. That's a practical significance, and many a times it's a question for you, short question.
yes,
Okay, continue.
As Rajshekar said, I think the nerve is very important because if the nerve is damaged, the patient's diaphragm for one part or will be non-functional, so their breathing becomes a problem. So I think just to give you an example, there was a patient who came with almost rupturing of the thoracic aorta, and the patient, and this was in Leeds, and the patient underwent surgery. He did extremely well, but unfortunately he couldn't breathe because the phrenic nerve was damaged, and patient was on ventilator for a long time and then finally succumbed. So though the operation was very successful, you could have there are so many other problems that could have happened. None of them, renal failure didn't happen, mesenteric vessels were fine, everything was fine except the phrenic nerve, and the patient finally succumbed because of that. So, as Dr. Reddy says, nerve is extremely important. The phrenic nerve is very, very important when it comes to diaphragm.
You need to be very familiar with the phrenic nerve, not just because it is the innervation to the diaphragm, but you can damage it in any surgery that you do in the neck also.
Yeah.
A huge goiter in the neck when you are dissecting, if you don't know the phrenic, vagus, different nerves, where it is, where it should be, how to recognize and preserve, you may end up damaging in the neck surgery itself. And then you may not even realize why the patient is struggling to breathe in the post-operative period. So entire origin, its course and innovation, you should know thoroughly. Next.
yes. Next, we'll discuss about diaphragmatic hernia. It occurs when the abdominal contents migrate into the thoracic cavity through a defect in the diaphragm. This conditional,
Sai, 1 second. It's not
yes,
you. Anyone else giving a definition of hernia in general? Simple definition of hernia, umbilical hernia, inguinal hernia, femoral hernia that you keep talking about. What is hernia?
Protrusion of content or a hollow viscous through the wall that contains it.
You are a consultant, lady.
Sorry.
I know you know. Allow the exam going PGs to answer.
Okay. Sorry.
Huh?
Nikita, are you there?
Who's the senior most? Ainas, are you there?
Yes, sir.
What is hernia? Definition of hernia.
Samir, are you come back? Samir?
No, sir, he's not there, sir.
Why is he not there? He said he will come back today, no?
Not sure, sir. For all of us, he told he'll be joining tomorrow.
Okay, leave him.
Okay. Ainas.
Sir, protrusion of an organ through a weakness or defect in the normal cavity of the wall, sir.
Containing wall.
Uh,
Containing wall. That should be very interesting.
yes, sir. Cavity that contains it. Yes, sir.
Not cavity, ma. It is a wall.
Wall. Yes. Yes, sir. Sorry.
Because there's a question you will invariably, if when you are doing one major case, 2 or 3 short cases, one of them will be a hernia. And if you are not familiar or confident in the definition of hernia, don't expect yourself to pass through the examination. You should just say it like that without hesitation. Okay, Sai, continue. Diaphragmatic hernia.
yes. Diaphragmatic hernia occurs when abdominal contents migrate into the thoracic cavity through a defect in the diaphragm.
Okay, now
This,
hold on. Why only
yes,
abdominal contents migrate through the diaphragm into the chest? Why not chest contents migrate into the abdomen?
because in thoracic cavity there will
Not
be
you, man.
negative.
Not you. Somebody else. You are the person who is presenting, so let others answer. Nikita, you there?
I don't think she is there.
Nikita is not joined. Why is she
Okay,
not?
Aina, you are the target. Next exam going. Tell me.
Sir, because the intra-abdominal pressure is
Okay,
higher than
listen to
in.
my question. When there is a
Yes, sir.
defect in the diaphragm,
Yes, sir.
contents from the abdomen technically can go up or contents of the chest can come down, isn't it?
Yes, sir.
But it's always the contents of the abdomen that go into the chest. Why is it?
Uh, so is it the intra-abdominal pressure is comparatively higher in comparison to the intrathoracic pressure, sir? And there's a
Intra-
negative pressure in the thorax, sir, which
Correct. Yeah, same reason why we connect the
like
chest drain onto underwater seal. We don't connect abdominal drain or a thyroid drain into underwater seal.
is
You are right. Yeah, intra-pleural pressure is always negative. That's why. Yeah. Okay, continue, Sai.
This condition may be congenital, resulting from the developmental abnormalities or acquired due to trauma or surgical complications. Coming to congenital diaphragmatic hernia, it is a developmental defect of the diaphragm that will result in the abdominal viscera into the chest cavity. It occurring at a rate of 2.3 per 10,000 live births. And more than 85% of congenital diaphragmatic hernia occur on the left side as posterolateral defect, classically referred as Bosch-Dallek defect, and right-sided defects and anterior defects or Morgagni type defect which occur with less frequency.
No. It's Boktalak, not Boschtalak. Boktalak is both left and right pleuroperitoneal, and the central is Morgagni.
Okay.
What
Yes,
Ravi Shankar said is correct. But why this posterior Bagdala hernia more common on the left side? You only mentioned
we
85% again as against 13% on the right side, isn't it?
yes,
Which organ is on the right side which gives a protection?
it is because of the liver. It is a solid organ.
Yeah. Okay. Hmm.
Yes.
What is the defect there during the development? Of all the components that you mentioned, origin of diaphragmatic components, which component is missing there?
In posterior lateral, sir.
Yeah.
It,
Ravi Shankar said it.
in
You
central
have also
tendon,
written it there, man.
pleuroperitoneal.
Yeah.
Yes,
Okay. Continue. Yeah.
yes.
Continue.
And the most common accepted theory behind this development is the pleuroperitoneal folds incompletely fuse, and the degree of incomplete fusion can result in a small defect or a complete absence of the diaphragm results in the diaphragmatic agenesis. In 10 to 20% of cases, the pleuroperitoneal folds likely completely fuse, but there is a failure of muscularization and which results in a sac, development of sac.
Okay. Continue.
Yes. In 60% of cases, congenital diaphragmatic hernia occurs as an isolated event. In 40% of cases, it occurs as a part of syndrome or association with congenital anomalies. And associated anomalies include congenital heart diseases and urinary abnormalities, intestinal atresia, and neurological defects. And congenital diaphragmatic hernia results in pathophysiologic triad of pulmonary hypertension and pulmonary hypoplasia and cardiac dysfunction. This pulmonary hypoplasia results in a limited surface area for adequate gas exchange, which further results in underdevelopment of pulmonary vasculature that impedes blood flow through pulmonary circulation, which causes pulmonary hypo
It's simply
hypertension.
because the
Yes,
abdominal contents are filling in that side of the chest.
hypertension.
And the component that you said 40% are associated with anomalies means if you see a child with a congenital diaphragmatic hernia, make sure you make every effort to rule out other congenital anomalies before you jump to fix the diaphragmatic hernia. That's what it practically means. Okay.
Yes.
Okay. Continue.
So what is the rate limiting step in terms of the recovery from the this one Bogdalac hernia usually? Anybody?
Did you understand the question?
Yes.
Ravi, can you explain them what the question is?
See, even let us say you've done a fantastic, perfect repair of the diaphragmatic hernia, but what is that which determines whether the child survives or what is the the prognosis of the patient of the child?
Right. Depends upon the condition of the lungs, which pulmonary
Yeah,
hypertension,
pulmonary hypoplasia. That is the main. That is
hypoplasia.
the rate limiting step. That
Yes.
that is how much of the lung is affected is finally what determines whether the child will do well or not.
Yes.
Okay, continue.
And this impaired gas exchange by limiting blood flow across the alveolar surface, and it increases the afterload on the right heart, leading to the heart failure, right heart failure. The diagnostic measures and required evaluations for con- congenital diaphragmatic hernia are classified as prenatal and postnatal. In diagnosis, prenatal diagnosis in up to 60% of neonates with a congenital diaphragmatic hernia is described by routine antenatal ultrasound screening during 18 to 22 weeks of gestation. And left-sided hernias is characterized by heterogeneous prenatal lesion in the left hemithorax and right mediastinal shift. That heterogeneous mass implies the herniated intestines. And the fluid within the mentioned mass and peristalsis assist in differentiating congenital diaphragmatic hernia from other prenatal intrathoracic lesions. In right-sided congenital diaphragmatic hernia, it is typically suggested by a homogeneous mass in the right side of chest on imaging studies. In the herniated liver, may or may not cause the left mediastinal shift. And the sonographic appearance of the liver is quite similar to the lungs, and therefore it may not serve as a reliable diagnostic marker. And the presence of pleural fluid and intestines are potential characteristics of the right-sided congenital diaphragmatic hernias.
When you said the last sentence, the liver and the lung look the same on the ultrasound.
Yes.
Why is it so? Because child is not yet born,
Okay.
it's not yet breathing. The lungs are not yet filled with the air.
Yeah.
They are solid organs. So they look the
Solid.
same in the ultrasound because you're talking
Yes.
about prenatal diagnosis.
Yes.
Okay.
Okay.
And in a child which is so small, to identifying the contour of the diaphragm and the missing component is almost impossible. It's just that additional two separate masses in the right side of the chest. You should have a suspicion that one probably lung and the other is probably the liver. Very rare on the right side and very difficult to diagnose the right side diaphragmatic hernia. Okay, continue.
Yes. In postnatal evaluation of hernia, the chest radiography indicates the herniation of abdominal organs, usually the intestines, characterized by air fluid containing structures into either right or left hemithorax with minimal visible aerated lung on the affected side. Further evidence supporting the diagnosis includes the contralateral cardiac displacement and impression mass effect of the over the contralateral lung and reduced abdominal girth. Occasionally, the herniated liver is the only sign suggesting the right-sided congenital diaphragmatic hernia. In this case, a large right thoracic solid mass without the normal abdominal shadow supports the diagnosis. Just coming to the management, mm, immediate surgical repair does not correct the fixed lung volumes nor expedite the vascular remodeling and subsequent resolution of the pulmonary hypertension. Therefore, stabilization of the infant should precede operative repair, which should be delayed until the pulmonary hypertension is controlled. The initial resuscitation in the newborn with congenital diaphragmatic hernia should focus on avoiding hypoxia, hypercarbia, and acidosis. And the permissive hypercapnia with spontaneous ventilation has been advocated, recognizing the need to maintain adequate gaseous exchange without injuring the fragile lungs of the neonate.
Ainas, what
In,
does permissive hypercapnia mean?
Uh, so basically, we are allowing CO2 retention, sir.
Why do you do that?
So as to basically it is to prevent ARDS, sir. So to avoid lung injuries, like you are accepting higher level of carbon dioxide, and which is avoiding lung injuries, sir. Like ventilator induced lung injuries prevented, sir. Like
No, see, that is only afterwards. But basically, what you are saying is in the higher level of carbon dioxide is
the
the drive for the child's breathing, because
Stimulate.
that is a
yes, sir.
stimulation for the child to breathe, and which is why you allow the carbon dioxide to be at a higher level than what is normally accepted, and hence maybe avoiding the need for ventilation till very late.
Yes, sir.
What is
and
ECMO?
yes, yes.
Carry on, man.
Yes. And in infants who are unable to maintain the adequate gaseous exchange and with impending heart failure, extracorporeal membranous oxygen has been used as a salvage therapy. And infants greater than 34 weeks of gestation and greater than 2 kgs are the candidates for the ECMO.
ECMO again is a short question for you because it's more and more centers, more and more often this is being used, especially COVID and post-COVID. What is ECMO? Anyone?
Uh,
Has
Yes,
anyone read about ECMO?
Karthik, tell us about
Sir,
ECMO. What
sir,
is ECMO?
ECMO is a extracorporeal membrane oxygenation, sir. We are giving the gas exchange, like we are exchanging the gas and uh, with the machine to improve the circulatory support.
Have you guys attended the open heart surgery, sternotomy open heart surgery, where they put the patient into heart-lung machine? Have you seen that?
No, no, sir.
You should go to a cardiac center and see that. Heart-lung
Yes,
machine is the one that does function of both heart pumping as well as oxygenation and removal of the carbon dioxide. ECMO is purely gas exchange function is done, meaning it only takes over the function of the lungs in a lung failure patient, like in a ARDS, where you need to support only the lungs. Veno-venous ECMO, veno-arterial ECMO. There are various types of ECMOs and various details in the ECMO. ECMO is basically extracorporeal gas exchange. That is the function of the lung is transferred to a external device, giving time for lungs to heal. So you can use this only in patients who have respiratory failure. Continue. You need to read more about ECMO. It is a question and you need to know about for your future practice.
Yes.
Continue.
And repair may be performed via open or minimally invasive procedures. The most commonly employed method is open, that is trans-abdominal approach. And in open technique, the most common approach of left-sided hernia is through a left side subcostal incision. And once the abdominal cavity is entered, a self-retaining retractor is helpful to provide the traction of the anterior traction cephaloid on the anterior chest wall, and the viscera are gently reduced. And once the hernia has been reduced, the malleable retractors can be used to keep the viscera reduced and out of the operative field. And if the diaphragm can be closed with minimal tension, then primary repair can be performed. If the defect is too large for the primary closure, then a patch must be used. Sometimes the medial aspects of the diaphragm can be closed primarily, but the lateral aspect lacks the adequate tissue for the closure, and a patch is required. A permanent mesh such as stretched polytetrafluoroethylene or biologic bioprosthetics are used for the mesh repair, are used for the repair. And recurrence after congenital diaphragmatic hernia repair can be high as 35% if patch was necessary. Therefore, most recently, muscle flap repair done using the internal oblique muscle flap, which has been shown to reduce the recurrence rates to as low as 4%.
It's your common sense if the defect is large because it's a congenital defect. Generally, defect will be large enough, you cannot primarily close it, and you put a prosthesis to cover the defect. As the child grows, that prosthesis is going to give way because prosthesis is not going to grow. Okay. As a
Yes,
result, you have a higher incidence of recurrence, so you may have to go back and repair again. To reduce that recurrence or tearing away, you use the oblique muscle, patient's own muscle, with reducing the recurrence rate. That's the common sense. Okay?
okay.
Continue. Hmm.
And survivors of the congenital diaphragmatic hernia are still at risk of other long-term problems like prolonged ventilator dependence and gastroesophageal reflux, reactive airway disease, neurologic sequel such as cerebral palsy, speech delay, and seizure disorders, and delayed growth. And these patients require lifelong multidisciplinary follow-up.
Before you
Yes.
go to traumatic injury, are there any reports where the diaphragmatic hernia is repaired while the fetus is intrauterine?
Right, right.
Because it's a
I,
prenatal diagnosis early in the child growth, isn't it?
yes.
If you allow it to persist as the child grows, you end up with hypoplastic lung. As a result of one lung being hypoplastic, circulation going through only one remaining lung, pulmonary hypertension, all other consequences with the risk of not survival. Can you repair it while the child is still in the intrauterine? Are there any attempts for that? Have you read any news about it?
No,
Read about
no,
it.
sir.
Yeah,
Yes,
thank
sir.
you.
Yes,
Continue.
yes, yes, sir.
Hmm.
Uh, Next, coming to the traumatic injuries to the diaphragm, the most common etiology of acquired hernia is secondary to trauma, which result in hernia. And the incidence of diaphragmatic hernia varies between in blunt trauma is 94% and in penetrating trauma is 15.1%. And the diaphragmatic rupture tend to occur more commonly on the left side of diaphragm, uh, likely due to the right diaphragm being protected by the size of liver beneath it. And the American Association for the Surgery of Trauma Organ Injury scale for the diaphragm is depicted in the table, which is grade 1 includes contusion, grade 2 is laceration less than 2 centimeters, and grade 3 is laceration between 2 and 10 centimeters. Grade 4 is laceration greater than 10 centimeters with tissue loss less than 25 centimeters square. And grade 5 is laceration with tissue loss greater than 25 centimeters square.
Yes, hold on. When he said 94% blunt trauma, he did not mean to say blunt chest trauma patients, 94% of them will have diaphragmatic hernia. All he meant to say is those patients who have a diaphragmatic hernia as a result of trauma, among them, blunt trauma is the commonest cause for diaphragmatic hernia. Is that a clarity?
Yes.
Okay, continue.
Yes.
Yeah.
Yes. And coming to chronic diaphragmatic hernia, these injuries, when frequently missed initially, may present later as chronic hernias. And a patient with missed or untreated diaphragmatic hernia present with delayed fashion of symptoms related to intestinal herniation or strangulation. And over a time, small diaphragmatic holes can increase in size as a result of constant activity of the muscle and the pressure gradient between the pleural and peritoneal cavities, which draw intraperitoneal organs into the chest. And the presentations may vary from mild nausea and vomiting due to intermittent bowel obstructions and pain from incarceration and ischemia to septic shock due to strangulation and perforation of the bowel.
You omitted a very two common difficulty in breathing and chronic cough. These are two very common symptoms apart from the ones you have listed. I think that again, patients may have just persistent and chronic cough or difficulty in breathing. So you have to be
Exertional breathlessness is
like
the commonest symptom.
commonest symptom. Yeah. So you have to be
Yes,
having a high degree of suspicion, especially if the patient has persistent, exertional dyspnea or cough. When you do the either a chest X-ray or a CT, you will get a diagnosis.
yes,
So when you have a trauma patient, if you see a patient with upper rib fractures, 1, 2, 3 rib fractures, you must rule out injury to the subclavian vessels and brachial plexus. Similarly, when you have a patient with lower rib fractures, 8, 9, 10, you must rule out diaphragmatic tear or injury to the abdominal viscera, liver, spleen, stomach, colon, whatever it is. If you are doubtful, evaluate with either ultrasound or a CT, keep them for observation. Don't jump to say that everything is normal. Okay?
yes.
Continue.
Next, coming to diagnosis, on examination, there are certain signs that are suggestive of injury, includes unilateral decreased breath sounds and bowel sounds in the chest and respiratory distress. And diagnosis of acquired diaphragmatic hernia mainly relies on imaging studies, and various imaging modalities are used to diagnose diaphragmatic hernia, which include chest radiographs, ultrasound, CT, which CT being the modality of choice, and MRIs. In chest radiograph, there is evidence of air or air fluid level within the hollow viscus overlying the thorax, or with the classical finding of coiling of supradiaphragmatic nasogastric tube, and also abnormality in the contour, shape, or position or elevation of the hemidiaphragm, and pleural effusion or atelectasis, and also mediastinal shift.
Okay, stop there. When you do a chest X-ray, what is the constant finding of the abdomen that you see in a chest X-ray under the left dome of diaphragm?
Fundus shadows.
Funding gas
No,
bubble.
no, fundus gas shadow. You said it correctly. So you have a patient with trauma or a history of trauma 6 months, 1 year back, comes now with vague symptoms, either chest and abdomen symptoms, and then you do a chest X-ray and you don't see the fundal gas shadow. That is the constant finding in a diaphragmatic hernia, absent fundal gas shadow. Rest all air fluid level, coiled NG tube, all these are your imagination. You should be really experienced to see that. Absent fundal gas shadow should raise the suspicion. What happened to the any X-ray when you see if there is no fundal gas shadow, you should ask yourself, what's happening? Why am I not seeing the fundal gas shadow? That curiosity will let you do the actual diagnosis. Continue.
Yes. And CT has the most sensitivity and specificity in diagnosis. And the suggestive findings include discontinuity of the diaphragm or a wound tract extending up to the hemidiaphragm and intrapleural abdominal contents. MRI has the high soft tissue resolution compared to CT. However, it has a limited role in acute trauma setting as it is more time consuming and costly. And it is absolutely contraindicated in hemodynamically unstable patients. And management is preoperative management is done according to the ATLS protocol, following adequate primary resuscitation. A long midline laparotomy incision is made, and primary evaluation of the abdominal quadrants and retroperitoneum should be undertaken. Any bleeding or gastrointestinal spillage should be prioritized, and control should be prioritized, and the diaphragmatic edges are trimmed and held with Alice clamps and retracted caudally to allow the adequate exposure, and thorax should be examined entirely to ensure a bloodless clean field, and accordingly the falciform ligament should be ligated and divided in and downward hepatic traction will assist in the improvement of right diaphragmatic evaluation. On the left, the stomach and spleen are retracted inferiorly and medially with gentle traction for left diaphragmatic evaluation. And the diaphragmatic central tendon and adequate firm attachments to the lumbar vertebra should be confirmed. And in the presence of abdominal visceral herniation, gentle reduction to the abdominal cavity should be done, and the repair of the injured diaphragm involves debridement of the devitalized edges, and the diaphragmatic repair is then undertaken with either permanent or absorbable sutures, and repair with running or interrupted sutures. And a prosthetic mesh and biologics are preferred for large defects or for those who where by primary repair produces too much tension.
I'm a thoracic surgeon. Can I repair this traumatic diaphragmatic hernia through chest?
Yes, sir.
Answer is no, because more or less these patients will have some intra-abdominal visceral injury. You cannot assess that by a thoracic approach. So it should be either a abdominal approach. If you suspect injury to both the chest and the abdomen, thoraco-abdominal, where you have equal access to both the chest cavity and to the abdominal cavity. Either through the abdomen or thoraco-abdominal, not only through the chest. Remember that. Continue.
And patients with an isolated diaphragmatic injury, a minimal invasive approach using laparoscopy repair may be considered. For chronic diaphragmatic herniations, a thoracotomy may provide better visualization for the difficult dissection. And this approach facilitates the identification of diaphragmatic ruptures and the release of adhesions between herniated abdominal contents to the lung and chest wall and their proper reduction back into the abdomen.
You're correct. Okay.
Yes.
Continue.
Yes. Mm. Next, coming to the hiatus hernia, it is It is characterized by the abnormal protrusion of the upper part of the stomach or the other internal organs through diaphragm's hiatus. In this condition, the stomach pushes through the diaphragmatic opening into the chest, compromising the lower esophageal sphincter. And this laxity of the lower esophageal sphincter may allow gastric contents and acid to back up into the esophagus, leading to gastroesophageal reflux disease. And small hiatal hernias are often asymptomatic and typically managed medically, and large hiatal hernias usually require surgery. And this may be congenital or acquired. And this development of hiatal hernia is multifactorial with contributing factors including congenital anomaly, anatomical defects, and increased intra-abdominal pressure seen in obesity, pregnancy, and chronic coughing, and age-related changes in the diaphragm's muscle tone. And this may be congenital or acquired, and its prevalence is increased among the older people. Approximately 55 to 60% of individuals older than 50 years have hiatal hernia. However, only 9% are symptomatic. Uh, Hiatal hernias are classified into four types. Type 1 is the sliding type, representing more than 95% of the hiatal hernias. And this type occurs when where the esophageal junction is displaced towards the hiatus. And uh, type 2 is hiatal hernia, which occurs when the part of stomach media migrates into the mediastinum parallel to the esophagus. In type 3, it is combined with the paraesophageal hernia is combined with the sliding hernia, where both gastroesophageal junction and a portion of the stomach have migrated into the mediastinum. In type 4, the stomach and an additional organ such as colon, small intestine, or spleen herniate into the chest. And gastric esophageal reflux disease is a typical presentation leading to an evaluation of hiatal hernia. And patients often complain of heartburn and sometimes regurgitation. And in some patients, presents with extraesophageal symptoms such as chronic cough. And dysphagia is also another problem seen in advanced disease, and typically secondary to the mechanical obstruction, which signify the presence of an additional pathology such as peptic strictures and tumor or diverticulum or primary motor disease.
Continue.
Coming to, yes, coming to evaluation in endoscopy is an essential step in evaluating the gastric esophageal reflux disease and a suspected suspected hiatus hernia patients. And a manometry also rules out primary motility disorders such as achalasia, which can mimic reflux symptoms. The and the 24-hour pH test is a gold standard for diagnosing acid reflux. In this study, a probe is placed 5 centimeter above the gastroesophageal junction and it measures the amount of acid that passes in that region. The data is then obtained is quantified using D-Mister score, which is based on several parameters that include the amount of time the esophageal pH is below 4 and the number of reflux episodes and the duration of longest reflux episode and the total number of reflux episodes lasting longer than 5 minutes. And a total score of 14.7 or above indicates the significant gastroesophageal reflux. And barium esophagogram also provides information regarding the esophagus and proximal stomach anatomy. And this study may also discover the anatomic abnormalities such as tumors and strictures.
This was the only investigation in the pre-endoscopy era. Barium esophagogram. Continue.
Ainas,
Yes.
how do you identify hiatus hernia in endoscopy?
If you are there at the time when the
Yes,
Ravi Shankar is doing a upper GI endoscopy, OGD, can you
yes, sir.
recognize, yeah, this is a patient with hiatus hernia?
Sir, we see how the scope is fitting, sir. Like if it is like the like at the level of hiatus, if it the scope is snugly fitting, uh,
No, no,
based on that you decide whether it is
nothing,
grade one,
nothing,
two,
nothing to
three.
do
Like
with fitting.
okay, sir.
Anybody else?
I don't think they know it, Ravi. Elwood.
Okay, so
Uh,
basically, first thing is you will see a significant portion of the esophagus with columnar metaplasia. So, because normally you have squamous epithelium, if there is a significant portion of the esophagus with the columnar, this one you will start to suspect it. Then you can see a ring of white tissue, which indicates that a portion of the stomach is coming up to the thorax. And then when you go into the stomach and do a J maneuver, you see that the lower esophageal sphincter and this one is very lax. So you normally it should be snugly fitting. You can't see any gap between the esophagus and the scope. But in the patient with the hiatus hernia, there will be a significant gap between the scope and the esophagus. So those are the things which will tell you that there is hiatus hernia. And the other thing is the distance. Usually you have, depending on how tall or how short the patient is, you see the gastroesophageal junction should be at a distance of between 36 to 40 centimeters, sometimes 42 centimeters. If it is much shorter than that, then you suspect that the patient may have hiatus hernia in the background of other things that I told you. Otherwise, we'll have to suspect a shortened esophagus, which is a different condition altogether. Did you
okay,
understand?
continue. Hmm.
All of you?
Yes.
You need to go to the endoscopy room and see how the esophageal mucosa looks, how the esophagogastric junction looks, how the proximal fundal stomach looks. Then you will understand what Ravi Shankar described. Continue.
Yes. And the management of hiatus hernia depends upon the type of hernia and the severity of symptoms. The initial treatment is given to a patient presenting with the typical GRD symptoms in an outpatient setting include double dose of proton pump inhibitors. In individuals with evidence of
Wait,
severe
wait,
ESO,
man, wait. See, the other most important thing is lifestyle change of these patients. You have to, one is to stop them to stop smoking and alcohol consumption. Second thing is, if they are obese, majority of them are, you have to ask them to reduce their weight because increased intra-abdominal pressure will cause the stomach to be pushed up into the chest because there is already a lax lower esophageal sphincter and also the diaphragmatic crux will be lax and hence there is a chance for herniation and if the intra-abdominal pressure is high due to obesity so you have to tell them to lose weight and second thing is that the majority of them have significant reflux symptoms so you should tell them to not sleep at least 2 hours after consumption of the food whether it is in the afternoon or night and to sleep with two pillows so that the thorax is at a higher level compared to the abdomen. So these are the
yes,
things you have to tell them and then in addition you have to give them proton pump inhibitors. So lifestyle change and proton pump inhibitors
proton.
forms the initial management of diaphragmatic hernias, hiatus hernias and if they don't settle with that and then there are many other criteria for which then you have to offer surgery.
Yes,
What are the criteria?
yes.
Tell us.
Individuals, yes.
Ah,
You have mentioned it there, man. Go on.
Yes, sir. Individuals with evidence of severe esophageal injury, such as ulcer, stricture, or Barrett mucosa, or patient with long duration or incomplete resolution of symptoms while on medical therapy, should be considered for surgical intervention.
So,
And para is
wait. Los Angeles grade 3 and grade 4, esophageal reflux esophagitis, presence of Barrett's esophagus, which is not amenable to medical treatment. As usually what we do is the argon plasma coagulation, and if with argon plasma coagulation, if the Barrett's esophagus does not recover or improve, then you have to offer surgery. Esophageal strictures secondary to persistent reflux, and as I said, Los Angeles grade 3 and grade 4 reflux esophagitis, and these are the indications for, and patients who are young, who will not want to take medication for the rest of their life, and who do not respond well to medical treatment. So these are the patients whom you should consider for surgical intervention. In addition, patients who undergo 24 hours pH monitoring and esophageal manometry, who have a Demister score above 18, usually 18 to 24. If they have scores above that, then you have to consider them for surgery.
yes,
Good. Continue.
yes. Coming to the surgical procedures, the Nissen's fundoplication, it is a 360-degree wrap, involves the complete wrapping the gastroesophageal junction using the stomach fundus. In this procedure, French 52 French bougie ensures the approximation without the wrap being too tight. The initial steps involve the dissection of short gastric vessels of the stomach greater curvature to mobilize the fundus, and the phreno-esophageal membrane over the left crust is thoroughly dissected and the crural fibers are identified. And the lesser momentum must be opened for the right crural dissection, and suitable phreno-esophageal membrane is mobilized, and the anterior and posterior vagus nerves must be preserved during dissection. And a Penrose drain is typically placed around the esophagus to assist in the mobilization and the creation of wrap, and the bougie is removed once the wrap is complete, and the wrap is anchored to the esophagus and hiatus to prevent the herniation of and slippage.
So before you didn't say something that is more important than just doing the fundal wrap. What is that? Most of the time, the crura, the esophageal hiatus is very wide, so you will have to do a crural repair as well. So you have to identify both the left and the right crux of the diaphragm, and then you put usually two sutures anteriorly, one suture posteriorly. That is so that the esophagus is now snugly fitting, and then you do the wrap. And nowadays the more one which is done is the toupee modification of Nissen fundoplication, where you do a 2/3 of the
He has that in the next slide, Ravi.
next
Next
slide.
slide.
Okay.
Yes, it is. And the two most common partial fundoplications are the door and the top-head procedures. And the door is performed by folding the fundus over the anterior aspect of the esophagus and then anchoring to the hiatus and esophagus. In top-head procedures, it creates a wrap around the posterior aspect of the esophagus.
Wait.
Yes.
It's not topet, it's toupee. Okay, so
Two.
toupee repair. But
That is pronunciation. Yeah.
um, where do you use anterior wrap, Sanya or Karthik? Karthik first, and Praveen, if they are not answering, and Sanya.
Okay.
Go on.
Are there any specific set of patients where you do only anterior, or are any indications where you have to wrap posteriorly like toupee? I don't think they know it, Ravi.
No.
No, Sanya, you don't know?
Sir, in Hellas myotomy, after
Ah,
doing
correct.
the
Yeah. So basically, for echalasia cardia, see, majority of the after echalasia cardia, patients will have significant reflux. So to prevent that, you do what is called as a DOR, anterior repair, which is only you bring the fundus anteriorly and wrap it around the esophagus. You don't have to do the more extensive posterior toupee or Nissen fundoplication. That is the only indication for DOR repair. If it is for hiatus hernia, you don't do DOR repair. Is it clear, all of you?
Yes.
Okay.
Next, coming to the complication, this can be
Okay, you skip
class.
this slide. Yeah,
Yes.
it's obvious.
That's,
It
yes.
depends on what organs you injure while doing the surgery. What happens
Yes.
if you accidentally damage the vagus nerve? While
Vagus.
mobilizing around the hiatus, you have accidentally damaged the vagus nerve. What does it mean? What happens next?
Vagus nerve, it affects the gastric emptying.
Hmm.
Yes.
So
So
what
if
will
the
you have to,
vagus is damaged, what will you do?
what will you have to do? You have to do a
We'll
drainage.
have to repair from the
No, you
fake
can't repair.
nerve graft.
You can't repair.
Ravishankar is saying it. Drainage procedure. What is drainage procedure? Oh, guys, you guys have to read this. Yeah. Okay. Next
Yes.
slide.
Yes. And these are the early post-op complications.
Okay. Hmm.
And these are
Okay.
the late post-op
Yeah.
complications.
Okay. You read it. Yeah. When you
Yes.
do typical surgery for the ulcer, vagotomy, what will you do along with vagotomy? Please read about it. Okay. End the
Yes.
seminar. Thank you. Well done.
Yes.
Well done. Well done. Yeah.
Thanks.
Yeah.
Thanks.
Any comments, Ravi?
I think you did well.
Yeah.
I think the anatomy, I think you presented very well. And the good thing is you were not reading from the slide. Your preparation of the slides was pretty good, and you were able to probably understand and talk. So that is something that you have to, all of you have to practice, so that you don't just read from the slide.
Oh,
I
he is
think
way
that
better. He is way better. And when he showed me the slides, there were no images at all. And he had a good amount of homework, adding images and presenting in a professional manner. Good. Well done.
Thanks.
Good night. Good night.
good night.
Mhm.
Thank you, all of you.